Good morning. I'd like to welcome all of you to today's Department of Psychiatry Grand Rounds. I'm Kelvin Lim, and I'm the Vice Chair for Research in the department. And it's my honor to introduce our speaker for today. Carol Peterson is a graduate of Yale and received her PhD in psychology from the University of Minnesota, and has been on our faculty now since, well, you've been with the department since 1994. Okay, and is now currently an associate professor in the department. And she's been successful in obtaining a set of grants from NIMH, R34 grants, to develop new treatments for eating disorders. And so we're very fortunate to have her today to talk to us about her recent findings from her R34. Thank you.
Thank you, Kelvin, and thank you for inviting me to speak at Grand Rounds today. And I also want to thank all of you for being here on this post-election morning under such profound circumstances. To start with disclosure information, our grant sources as well as royalties from a book I've co-edited and co-authored. I will not be discussing off-label or investigational use, sort of an interesting area within eating disorders, so we may veer into that in question and answers, but that's not part of the presentation. Here's what I would like to cover this morning. First, a few minutes about how we define eating disorders, and then some rationale of why we would need additional treatments. And then the bulk of the time I want to focus on how our group has been trying to target maintenance variables to improve treatment in eating disorders. So to start with definitions, what I'm going to be mainly focusing on today is our research in bulimia nervosa and binge eating disorder, which I'll talk about in more detail in a minute. And not to neglect anorexia nervosa. In fact, if there's one area where we need treatment most dearly, it's in this area, and I'll say a few words about how we're trying to expand our work into that area. And then in the DSM, there's also feeding disorders, as well as the other specified and the unspecified feeding and eating disorders. One of the most I would say contentious and controversial aspects of trying to measure and define eating disorders is the construct of binge eating. And there's actually been lengthy debate for several decades about how to define what binge eating is. And currently in the DSM-5, as it was in DSM-4, a binge eating episode is defined as eating in a discrete period of time an amount of food that is definitely larger than most people would eat during a similar period of time under similar circumstances. And if you look at the history of the classification of bulimia, what you typically see is that it was guided by some of the feeding lab studies that were done in the 1980s and 1990s that found that a typical binge eating episode was about 3,000 calories. And I think that's what really drove this idea. But what we know now from very robust data is that our patients with eating disorders have all different types of size of binges. So it may be a gallon of ice cream, or it may be mayonnaise on a salad that they hadn't planned to have. So at this point, this is still guiding our criteria, and what it means as clinicians and clinical assessors is we spend a lot of time trying to pinpoint whether an episode of food consumed was objectively large. And in the DSM-5, binge eating is defined as well as requiring a sense of lack of control or loss of control over eating. So a feeling that one can't resist eating or unable to stop eating, or feeling driven or compelled to eat. So to define bulimia nervosa within the DSM-5, it requires these types of binge eating episodes at least once per week, accompanied by compensatory behaviors, which typically include self-induced vomiting, but we also see misuse of laxatives, diuretics, fasting, and excessive exercise. And one of the other required criterion is the undue influence of weight or shape on self-evaluation. And what this means is that within how an individual defines themselves, within their self-esteem or self-concept, that this is strongly influenced by their weight and or their shape, more so than what we would see among other individuals in the population. And then within the DSM-5, anorexia nervosa is also an exclusion criteria. We do see binging and purging among people with anorexia nervosa, but those individuals are given the binge eating and purging subtype of anorexia. They're not given a concurrent bulimia nervosa diagnosis. The DSM-5 notes the first inclusion of binge eating disorder as a formal diagnosis, which actually belies the fact that within the eating disorder field, we've been studying it for many decades. This group of individuals is characterized by binge eating episodes at least weekly without compensatory behaviors. So what you typically see, this group is phenotypically more likely to be overweight or obese. But it's also noted to have that the criteria include marked distress about binge eating and associated features including eating more rapidly, eating until uncomfortably full, eating when not physically hungry, and feeling disgusted, depressed, or guilty as a result of the binge eating. And one of the reasons these psychological criteria are included was the concern that since binge eating is to some extent normative within our population, there was questions about trying to make sure we didn't pathologize something that may exist in a more normative way as well. So this brings the question of what are the evidence-based treatments for eating disorders. And those of you who do treatment outcome research are probably familiar with the National Institute for Clinical Excellence in Great Britain, which is an organization that worked to review all of a very comprehensive review of all of effectiveness treatments to really try to determine, based on the amount of data and the quality and the degree of efficacy in each treatment study, what degree of efficacy you were seeing across different kinds of treatments. And in eating disorders, we ended up getting A grades for two of our, for both bulimia nervosa and binge eating disorder for cognitive behavioral therapy. What you typically see in eating disorders is that we're sort of the young cousins, if you will, compared to other areas of psychopathology. So what we've typically done is adapted treatments that have been designed for depression, anxiety, and substance use, and adapted those to our treatments. And so cognitive behavioral therapy was giving an A grade because there's a lot of data supporting it, and the data are very significantly positive. Interpersonal therapy, which was adapted from Clareman et al. For depression, has also been found to have comparable outcomes at follow-up, but there's just less data supporting it. And then dialectical behavior therapy, which at the times that the NICE guidelines were published, hasn't been studied in bulimia nervosa and has been since then, was given a B grade. So this looks encouraging as well. And I should add that the NICE guidelines are currently under revision. In our field, we've also seen a fair bit of support for self-help and guided self-help. It looks like a subgroup of our patients do well if they're given cognitive behavioral therapy materials in the context of written form. And then there's actually a large literature on medication, particularly SSRIs, showing that they're effective, but they don't typically maintain efficacy over the long run. But having said this, why would our research group then embark on trying to develop a new treatment? Well, this has been this set of concerns has been plaguing us for decades now. And the first is that we see very significant improvements in symptoms. So if you're measuring baseline to end of treatment bulimic symptoms, you see very significant reductions. But when you actually look at full recovery or remission, if you look at abstinence of symptoms, those rates are more modest. And the problem is that it's that group that's still binging and purging at the end of treatment that are more likely to relapse. We also see very significant dropout rates, typically 20 to 30%, which suggests that our treatments are not always acceptable to our patients, and high relapse rates really across diagnoses that are really, I think, suggesting that our treatment effects are not consistently enduring. And then finally, this has been a significantly notable problem in the eating disorders area, and that is that there's a lot of limits in implementation in the community of our evidence-based treatments. And at times this debate has been heated, but what we do know is a lot of times our clinicians don't find our research-based, evidence-based treatments particularly user-friendly. So the idea several decades ago when we embarked on trying to develop a new treatment was that having other treatment options may be really helpful in producing more full remission among our patients with eating disorders. But then the question came, how can we actually improve eating disorder treatment outcome? And my one of my mentors, Steve Wunderlich, who's at the University of North Dakota, really gets credit for, I think, inspiring our group early on, because what he emphasized and has obviously followed suit in the context of RDoC from NIMH and broader areas of psychopathology is that in eating disorders we had to just stop adapting other types of treatments. We really needed to figure out the maintenance variables that were maintaining eating disorders symptoms and be more effective at targeting those. And in fact, Strawman and Merrill wrote about this in 2004, that the effectiveness of treatment and prevention improves when empirically supported causal and maintenance factors of psychopathology or behavior problems are targeted. And I think in eating disorders, this is especially a concern because of the complexity of causal and maintenance symptoms. We know that there are underlying risk factors. I should add, when I started in this field in 1985, we really thought most of these were going to be sociocultural, and it turned out we were quite wrong, that genetics obviously plays a huge impact as well, and gender, obviously. And then what we know from longitudinal studies as well as clinical data is there's typically a precipitating event, some stressful event, a school transition, the start of high school, the start of college, or something more presumably innocuous like going on a diet that then precipitates the onset of eating disorder behaviors, binge eating, purging, fasting, and other kinds of symptoms. And then one of the most problematic aspects of treating eating disorders is the power of these maintenance factors. There's an array of positive and negative reinforcement that is psychological and neurobiological. So there's been a number of comprehensive reviews of these various maintenance mechanisms, and what the data suggests is that there's a combination of various psychological, neurobiological, and potentially neurocognitive aspects, including nutritional deprivation, actually being undernourished, as well as the attempt to diet, body dissatisfaction and overvaluation of weight and shape, the thinness ideal that's been internalized, interpersonal factors, neurobiological factors, neurocognitive factors, personality factors, and emotion. And our group became very interested in the context of trying to develop a new treatment, understand these maintenance mechanisms better, is how we can measure these precipitants more accurately. And as a result, our colleagues in North Dakota started us along the research line of ecological momentary assessment. So this is usually a good moment to figure out how old everyone in the audience is. Does anyone else recognize what this is? Yes, well done. So there's some people in my cohort here. This, first of all, shows how old I am and how long we've been doing this research. This, for those of you who don't recognize it, is a Palm Pilot. Prior to cell phones, this is what we had for handheld technology. And in fact, we had a bit of a frantic time when we were trying to buy up every one of these on eBay as they became obsolete because all of our systems were set up for using them. But EMA was actually developed by a group of individuals who were studying smoking cessation, and it's been used widely in behavioral medicine and pain, because we know that when we ask people by questionnaire what they're thinking, what they're feeling, what they're doing, what their pain perception is, that they're going to be influenced by how they're feeling in the current moment. And this retrospective recall bias influences all of the information that we report. The advantage of EMA is that you're really trying to do behavior sampling in real time, which means you're sending people off with some sort of measurement. And in the past, we would use paper. Now we can use cell phones. I'm happy to say we have updated since using our Palm Pilot approach. But the idea is that you can use signaling or other kinds of ways of having people know what they're thinking and feeling in the moment. So, for example, this is the PANIS, and I'll show you some data from this in a moment. But we'll say, what is your current mood? And there's a list of things, and they report, how enthusiastic or happy they're feeling. And they can't go back and look, so they submit it, and then it sort of disappears from sight, so that whenever they're making ratings later, they're not going to be influenced by their previous ratings. And this approach is especially useful when you're looking for these kind of momentary maintenance mechanisms, because it's really giving you a glimpse in time of what's happening in the moment. So one of the early studies that our collaborative group did was with a heterogeneous group of obese binge eaters. And what we looked at is there's various ways you can do EMA recording. We looked at event-based, so we had them fill out a recording of their mood and their behaviors prior to and after each eating episode, whether or not it was a binge eating episode. We also semi-randomly prompted to make ratings 6 times a day, and then we had them fill out end-of-day ratings. And so we had them carry the Palm Pilot for 2 weeks. We had them trained at first and had them practice before they started. And then we paid them $150, and if they did a high enough percentage of those interval ratings, we gave them an extra $50 bonus. So what we did first is look at more simple correlation. And what we did is classified episodes of eating as binge eating or non-binge eating episodes based on their dimensional ratings of whether the amount of food was large, was it an overeating episode, did they feel a loss of control. And here you can see for negative affect that the binge eating episodes were correlated with much higher negative affect than the non-binge eating episodes. And the same was true for anger and hostility and stress, and the opposite was true for positive emotion. And Kelly Berg, who was our colleague here until she recently left to move to Portland, but is very much still a part of our group, did multi-level modeling analyses to take this interpretation of the data to an even greater degree of specificity. And what she looked at is what the negative affect looked like prior to time zero here, which is the occurrence of the binge eating episode. And what you can see is negative affect increases in the hours prior to the onset of the binge eating episode, and then comes down afterwards. So what this means, we many times have patients coming to us in great distress about their binge eating episodes. But what I think our momentary data show is that indeed it's still functional. Even though they don't like the fact they're doing it, it's effectively bringing down their negative emotion. Kelly's particularly interested in different facets of negative emotion, which overlaps with our interest in self-oriented cognition. And in fact, she found, looking at these different aspects of emotion, fear, hostility, sadness, you saw the most pronounced effect with guilt. Now, guilt about what we're less clear about, but clearly guilt was especially pronounced in this increase and reducing pattern. And this study actually replicated an early study that was conducted by our colleagues in North Dakota, looking at Bulimia Nervosa, who found the same pattern. So they found that negative affect rose prior to the onset of the binging episode, and then it reduced. And you see the same thing with purging behavior, and we see the same thing with binge eating behavior among people who have anorexia nervosa. And then Kelly replicated this with the Bulimia Nervosa group, and she found yet again the same pattern, that negative affect in the context of guilt seems to be particularly pronounced in this increasing and reducing pattern. So just to summarize, binge eating appears to be functional in reducing negative emotion among individuals with eating disorders, and binge eating and purging may be maintained through negative reinforcement. Now, it's really important at this moment to emphasize that this is not a new concept. This is something that, within the popular literature and clinically we've obviously known for decades. What's different, though, is the precision with which we can look at this and the timing of when exactly each of these types of precipitants occur. But in this context, we've been trying to use these types of EMA findings to inform our treatment, which culminated last year in the publication of our a treatment manual that we ended up, after many evolutions of name changes, calling Integrative Cognitive-Affective Therapy for Bulimia Nervosa, or the nickname being Ikat. What we decided as we were trying to put our new treatment together was that it didn't make sense to abandon the aspects of treatment that we think are very robust in existing models, especially cognitive behavioral therapy and DBT. So we kept those in place: behavioral exposure, planned meals and snacks in the context of nutritional rehabilitation, skills emphasis, and relapse prevention. But what we did was put a much greater emphasis on the role of emotion and on targeting these negative affective precipitants of binge eating, as well as what precipitates the negative affect. And this was really drawn by our ever-evolving ICAP model. What you see here is that the bulimic behaviors, so dietary restriction, purging, binge eating, exercise, are precipitated by high levels of momentary negative affect. And our treatment targets these negative affect occurrences as well as precipitants of these negative emotions. So these include relationship situations, things like, my boyfriend didn't call me. A momentary self-discrepancy. Self-discrepancy is a concept developed by Tori Higgins, and it's this idea that in conceptualizing the self, that we make comparisons to what we believe our desired self should be, either how we believe we should be, our ought self, or how we want to be, our ideal self. And the bigger the gap between the self-perception and the desired self, the higher the negative affect. So we see this among our patients with eating disorders, for example, around weight and shape, as well as performance at school and other domains. So, for example, I should be thinner. And then we also were influenced by the work of Lorna Benjamin and the SASB model of self-directed style and looking at self-directed cognition or behavior. So excessive control and perfectionism, as well as self-neglect and other areas that can contribute to negative emotion. And then in our preliminary data, we also found that it was important to keep more straightforward eating situations in there. So for our patients, suddenly to see that they're serving pizza can elicit very negative emotions as well as other responses. I won't spend a lot of time on the data to support the Ikat model, except to say that we're very lucky to have a multi-site T32 program, and our postdocs in particular have done a really masterful job of using EMA and other types of data to support what we've been trying to lay out in our conceptual model. So for example, we have very robust data now showing significant emotion regulation deficits in the context of eating disorders, especially as it relates to symptoms, increased self-discrepancy, so again, that difference between self-perception versus desired self that seems to be related to binge eating symptoms, negative self-directed behavior, including excessive self-control and perfectionism, and interpersonal problems, including interpersonal stressors that seem to directly precipitate these types of binge eating and purging symptoms. So our Ikat treatment is an outpatient treatment, and it's time limited, typically 21 sessions over 4 months, and that duration was really designed to match what's existing out there in eating disorder outpatient treatment, again with the skills emphasis, and we spent a lot of time delivering information related to psychoeducation, having our participants do a lot of self-monitoring work and homework. And I would say what makes Ikat especially different from some of the other approaches is that we're emotion focused in really a different way than DBT or CBT, really been influenced more by Leslie Greenberg's work. If there's emotion in the session, we stop and really focus on that in a momentary way. So we'll look at it in the context of self-monitoring of emotions that may have been triggering to eating disorder symptoms, but also as they relate interpersonally within the therapy session and outside of the therapy session. So I don't want to spend a lot of time on the detailed content of our work, just to give you an overview of it. We spend the first couple of sessions doing motivational interviewing, following Miller and Rolnick's model. Most of our participants, even if they want to, if they're highly motivated, still have some ambivalence about changing their patterns, probably in all likelihood because of the emotion regulation piece. And then we do a lot of focus originally on emotions. And this is a powerful moment when we say to our patients, one of the things we're going to be focusing on here is emotions and having you understand them and sit in the room with them and feel them. And this can elicit a strong negative response, but we really do believe it's one of the critical parts. And then we introduce self-monitoring, which continues throughout the treatment. Phase 2 is probably most similar to cognitive behavioral therapy, where we give the rationale for why meal planning and eating more regular meals and snacks is generally helpful. We also give adaptive coping strategies that they can use from a skill-based perspective and have them work on goal setting. Phase 3 is the one that really probably incorporates our EMA models the most. We work collaboratively between the therapist and the patient to figure out from the self-monitor data what kind of precipitants of negative emotion are most linked with eating disorder symptoms, and then we'll target individual parts of this or a combination as far as the interpersonal, the self-directed, or the self-discrepancy. And what we do is emphasize what we call the C change, situation, emotion, action. We're really trying to target these in a systematic way. And then phase 4, again, very reminiscent of CBT, where we focus on healthy lifestyle and relapse prevention. So my colleagues described the several decades leading up to our R34 grant as the dark ages, because it essentially was we would pilot the manual, we'd find the problems, we'd change the manual, we'd pilot it again, we'd change the manual, we'd pilot it again. But finally, and I'm sure partly because of all of our pilot data, we were given funding from the NIMH to compare our Ikat treatment with the gold standard treatment for Bulimia Nervosa, which is cognitive behavioral therapy. And the Oxford group who developed cognitive behavioral therapy for eating disorders had just done a new manual at the time that we started this trial called Enhance, which was a little bit different from the older models. So what we did in this study is looked at eating disorder and associated symptoms, looking at depression and other aspects of eating disorder comorbidity. But we also spent a lot of time trying to figure out the best way to measure hypothesized maintenance mechanisms. So looking at both cognitive self-discrepancy and emotion regulation. And here's what we found. There's no significant difference between these two, but we were really pleased to see high levels of retention in both treatments. And what you're going to see on this next series of slides is baseline, end of treatment, and follow-up data, where the yellow is our new Ikat treatment and the red is cognitive behavioral treatment. So what you can see is we had very significant reductions in binge eating over the past month, and very similar reductions in purging. And you can see we had reductions without a lot of relapse, which I thought was encouraging, but no differences between the two treatments. And then our EDE global measure looks at attitudes towards weight and shape, avoidance behaviors related to shape and weight and eating, and dietary restraint. And you can again see similar reductions, no differences between the two treatments. And then also similar pattern for the Beck Depression Inventory, significant improvements, no differences between the two treatments. So when you look at our effect sizes, you can see we had large and some very large changes over the course of treatment and follow-up, and especially for our global scores. So what this suggests is we're really seeing changes in these attitudes towards weight and shape and overvaluation of shape and weight. But this is where our results get a little bit more mixed. So the good news is we saw no difference in abstinence rates between our new treatment, Ikat, and the cognitive behavioral therapy treatment, which is really, very exciting on some level that we sort of match the state of the art. The bad news, though, is you can see our abstinence rates, we're really only getting about a third of people completely free of binge eating and purging. Slightly better for the completers, and there's no significance between the two. But what this suggests is we really need to continue working on how to increase that abstinence rate. How do we get more people completely free of binging and purging, not just have them reduced, but really get them in remission. The other part of our data that was a bit more mixed is our hypothesized mechanism. So indeed, we did see significant reductions in problems with emotion regulation, but no difference between the two treatments, and the same was true for our self-discrepancy. This then led us to follow-up analyses looking at moderator effects. And for those of you who do treatment outcome data, you know that moderators are really powerful because you're looking at baseline factors that define subgroups who have greater versus lesser intervention response. So, for example, you're likely to see very different responses of these two different animals as they're trying to swim through the ocean, although frankly it looks like the cow is keeping up pretty well. But the advantage then is that we can figure out whether our treatment's working especially well for a subgroup, which may give us clues to what may be useful, what kind of mechanisms we may be effectively targeting, ways of potentially improving our treatment and ways of potentially breaking it off into different modules. The first paper was published by two of our wonderful T32s who are here, Annie Haynos and Carrie Pearson-Carter. And they did an empirical classification of our data and found three subgroupings. Over-controlled, which was a group that was high in compulsivity, under-controlled, which was high in stimulus-seeking and self-harm, and then a low psychopathology group. And one of the most important parts of this finding is this is a highly robust finding. So if you're looking at inpatients, outpatients, whatever mixed group of eating disorder symptoms you're seeing, you typically see this breakdown. And what Annie and Carrie and colleagues found is that the over-control group really seemed to do better in CBTE, which I think tells us that treatment may do a better job of targeting that subgroup. And this paper was complementary with the work done by one of our former T32 postdocs, Erin Accurso, who was at the University of Chicago site and is now on faculty at UC San Francisco. And what she found in her analysis was that those higher in stimulus seeking showed more improvements in Ikat than CBTE, and those who had lower stimulus seeking had more improvement in CBTE. Also that participants with higher affective lability showed more improvement in bulimic symptoms in Ikat. So it looks like our treatment did an especially good job with a subgroup. And just to summarize what the bulk of this treatment has shown so far is that both our treatment and the comparison treatment showed significant improvement between baseline and end of treatment and follow-up, with no differences between the two on any of the outcome measures. Both treatments showed improvement in our hypothesized maintenance mechanisms, so we didn't see specificity. That CBTE was more helpful for those high on measures of compulsivity, and Ikat was more helpful for those with affective lability, dysregulation, and stimulus seeking. So where does that take us next? And that's, to some respects, where we are now. So the first question is, and it's tempting sometimes when you get moderator effects like this, to say, let's just focus on that dysregulated group and see what we can do with them. That's typically 30 to 40% of our bulimia nervosa population. But I think that's problematic as well. Nonetheless, that is one area that we're looking at. But I think one of our main focuses now is trying to figure out how we can improve our overall outcome, especially with the incorporation of technology, and also by trying to more fine-tune our understanding of these maintenance mechanisms. One of the grants that we're working on right now with one of our colleagues at Central Florida, who has a cell phone, iPhone-based app for increasing cognitive control. We're going to do an R61, R33 study where you, for MNIMH, where you try to first show effectiveness of your target, and then you can put it in a randomized trial. So what we're trying to do is take a group of people with binge eating and bulimic symptoms and seeing if we can really target that through inhibitory control and see if this can help us improve that actual behavior measure. It looks like we're very good at looking at the attitudinal piece, but we need to figure out how to better bring down that frequency of behavior. I'm also really enthusiastic about the start of a new treatment study that we're going to be beginning our recruitment in January. Our colleagues at Drexel, led by Adrian Gerasio, approached us several years ago and said, hey, what if we develop an app that you can use along with your outpatient psychotherapy? And we're like, well, that sounds great. Do you guys know how to program apps? And it turns out they really did a beautiful job. So what they've done is created what they're calling the Ikat Plus app, in which our patients are going to be carrying it around and using it through the course of treatment. And what it does is combine EMA assessment with what we call ecological momentary intervention. So they'll be paged at various points and signaled, and they'll fill out how they're feeling, what their behaviors are, how long have they gone since their last meal. And then what you can see here, this is a screenshot, it says, you are at risk for potential eating disorder behavior. And then you can click on it, and then it guides you through, and it either takes you to a section on specific skills you can use, or it says, these are things you could do to improve your mood right now, or you need to stop and have a meal, you're at risk. And it's been very compelling. We've been piloting it among our research team, and we're very excited to start our use of it. The Drexel group is just starting, and we're with their patients this week. So we're hoping that this sort of interaction will really help us generalize what they're learning in treatment outside, especially, again, we think this is especially well suited with our treatment given that focus on momentary precipitants. I also want to say a few words about ways that we're trying to conceptualize Ikat and the Ikat model for anorexia nervosa. And as I mentioned, this is probably the area in eating disorders where we're most in need of more effective treatments. There's very promising data for the treatment of adolescents using family-based treatment, but we really struggle with how to effectively treat anorexia in outpatient, as well as in intensive and other sorts of residential models. So we're going about this in two ways. The first is really trying to do a better job of identifying maintenance mechanisms. We don't understand them very well in the context of anorexia, but we know that to some extent they look different from what our models are for bulimia and binge eating disorder. Our group is working in multiple directions on this, including several of our postdocs are looking at aspects of reward. And I've been really thrilled with the collaboration that we've been doing with Calvin Lim and Katie Cullen, where we did a comparison of women with anorexia nervosa compared to those without in an fMRI study looking at emotion perception. And Leah Jappy, who was one of our students who's now at the Oklahoma VA, for her dissertation found very significant differences in emotion perception, specifically in the ACC. And what was interesting, the perception of fear faces was associated with hypo-responsivity, not hyper-responsivity. So we're really trying to understand that better. And now Annie and Jasmine Kamchong are working on more analyses looking at connectivity. So we're really hoping that this kind of fMRI data can help us inform our models. We're also working with a group at Columbia. Joanna Steinglass is the PI on this research, in which they've been really trying to fine-tune behavior treatments, including exposure treatment and the adaptation of habit-based models for treating anorexia eating patterns. And we're in the midst of revising a grant for resubmission that combines aspect of Ikat, especially around emotions, with these behavioral-based interventions. So again, this is an area of very significant importance and one that we're continuing to work on. We're also in the process of adapting Ikat in two ways. The first is for the treatment of adolescents and their families. Jocelyn Lebo, who's a collaborator of ours at Mayo, was just awarded a foundation new investigator grant to look at the use of Ikat for adolescents who have binge eating and bulimia, and working with their families and the adolescents. So there's pieces of it that are similar, and there are pieces that are going to be adapted for use with the families. And then finally, what's really taken a lot of our focus over the last several years is adapting Ikat for the treatment of binge eating disorder. And obviously the timing was optimal given its inclusion in the DSM-5. But what we started to realize as we were amassing our data for our Bulimia Nervosa study was that it looked like it was working well, and especially what we were hearing clinically from our research participants was they found it especially useful for binge eating. So we decided to collect some data to see how it looked for binge eating disorder. We just did a case series. But you can see for the pre and the light and the post and the blue, we had very significant reductions in binge eating and significant improvements in the Beck depression inventory. So we use this as well, along with our other R34 data to get a new grant, which we're in the process of working on now. This is an R34 study in which we're looking at Ikat for binge eating disorder and compared to guided self-help cognitive behavioral therapy. So this is as I mentioned earlier on, there's a fair bit of efficacy data supporting the use of guided self-help, and there's a recent study actually found that the cognitive behavioral therapy and the guided self-help format did as well as interpersonal therapy for binge eating. So as a result, we ended up choosing this as our comparison rather than the more standard cognitive behavioral therapy. And we're doing a 2-site study with 56 at each site. We've enrolled number 50, and we're about to randomize number 51. So fingers crossed, we're trying to finish by the end of the year. One of the most interesting parts of this process was trying to adapt our manual from bulimia nervosa to binge eating disorder, because when we looked at our EMA data, frankly, the two look very similar, but we tried to understand what some of the needs would be within the context of binge eating disorder, as well as some of the pieces that we really wanted to tinker with. And one of the things that we added was behavioral activation, which is obviously adapted from the treatment of depression, where we're having people focus on adding in positive events, especially those involving movement, because from a mood standpoint, we're hoping it elicits positive affect, but it's also potentially helpful, and we're looking as a secondary outcome measure whether we end up impacting weight and BMI. One of the other pieces that I think we learned a lot about from our last study was the importance of understanding mediators. So we've done a lot more measurement in this trial of our hypothesized mechanisms throughout treatment. And what we've done as well is used EMA as our at baseline, end of treatment, and 4-month follow-up as a way of trying to measure outcome. And what's exciting about this, so what this means is, again, no longer our Palm Pilots, but our participants are walking around with their cell phones for a week at the beginning and end of treatment and at follow-up. So what we're hoping then is we can look at our standard outcome, binging and purging, but we can also look at what things look like, how things change in that momentary model, since that's what we're so focused on targeting. And finally, I'm very grateful to the Department of Psychiatry for granting us a Psych Drive grant. As a result, and in collaboration with Katie Cullen, with a lot of help from Tricia Karstead, we've added in fMRI for a subgroup at our site with an emotion regulation task looking at baseline and end of treatment. We're really hoping that this will help us understand and identify biomarkers so we can understand from a neurobiological perspective what's happening as well. Before I finish, I first want to acknowledge my incredible collaborators, many of whom are here, and I'm so grateful for them in so many respects, both personally and professionally. We are also very fortunate to have a long-standing and very friendly collaboration with our friends in North Dakota, except around March Madness when things get very competitive. I'm also really grateful to my colleagues and friends at UC San Francisco, Daniel LaGrange and Aaron Accurso. And one of the best parts of having a T32 grant with postdocs is how much as a faculty member you get to learn from them. So I'm truly grateful to all of our T32 faculty and also our students. And those of you who do treatment outcome studies know that you cannot do this work without a very large cast of devoted researchers. And so again, I want to especially express my gratitude to Katie Cullen and Kelvin Lim for helping us further our program of research into the neurobiological realm. Our study therapists who've worked so hard in doing this work, those of you who've done therapy in the context of a research study know it's tricky because the audio tape is on and you're being monitored and rated. And then also our research staff who's been so devoted in recruitment, in assessment and data collection, and in fMRI. And with that, I'm happy to take questions. Do you want to call on people? Or?
Sure, I'll call on people.
Thank you, Kelly. In the research that you've done, I'll repeat. In the research that you've done, are there differences between patients who are on medication going through these treatments versus those that are not?
Yeah, so the question.
There's a lot of controversy about whether meds even work for
Yeah,
you.
there's a lot of questions about medication. It's true. Okay, first of all, I have to say, I have to modify when I said I would not discuss investigational use. I'm about to discuss non-label use because other than Prozac, which has got FDA approval for bulimia nervosa, none of the other meds do. So it's an interesting question. And what we did in our early treatment studies that I didn't talk about today is we excluded individuals who were on medication for that specifically, which then turned out to be meaning that we could recruit no one because pretty much everyone in the community was being put on medication. So what we've done is follow along with what you're seeing in other areas of psychopathology where we require individuals to be on a stable dose of medication for 8 weeks prior to enrollment. And then we monitor what they're doing. What we used to do in our trials is say, please do not change any of the medications you're on, and then we find out later there's all kinds of changes, or they'll start seeing another therapist, or this kind of thing. This is the challenges of doing treatment outcome research. So what we do now instead is try to assess what they're doing and what they're receiving. So far we haven't found a significant impact. We've looked at it in a couple of our studies, but I think it's one of the complexities that we see, and I think that at this point, at least for bulimia nervosa and binge eating, I don't think we can say definitively. I will say, again, this is where I'm talking about off-label use. In earlier studies that compared CBT with medication, we were all, this was in the 80s, and we were all so excited. We knew we'd have a great additive effect. You'd have CBT, and you'd add medication, and then you'd have an even better effect. That's not really what we found. But it looks like the medication was helpful at times for depressive symptoms and anxiety symptoms. And the one study that did find that the combination was best was done at Columbia. It was a multi-site study run out of Columbia. And what they found is if you let the psychiatrist change medication sort of in a more sort of naturalistic way, then you can potentially see that effect. So anyway, that's what we're doing now. We basically measure it and use it as a sort of noise variable, if you will.
Other questions?
I work in a residential treatment center for 12 to 18-year-olds, so I'm interested in your adolescent program.
Yeah.
There they stay 6 to 9 months in this program, and we see many diagnoses, but oftentimes eating disorder types, which tend to be mercurial. That is, they come for a while and they go away, and then they come back and they shift from purging to this or that. How close is the study with Mayo coming to something that might be used in a nice setting like ours to manage these problems?
Well, first of all, thank you for that question, because it gives me the opportunity to say that one of the biggest difficulties we have in understanding that high acuity population in eating disorders, which many of our patients are, is that there are essentially no randomized trials looking at residential or intensive treatment. So basically what we do in those settings is try to adapt what we've been doing in outpatient for residential. So I just want to say a caveat that that it's basically what we're trying to do is by extrapolation. And I should say, I was part of some research collaborations from several decades ago where we did try to submit grants to the federal government to do intensive treatment trials and residential treatment trials, and you can imagine they were not pleased with the budgets because that's really expensive work to do. But what I would say at this point is that the data on the use of family-based treatment for adolescents with anorexia and for bulimia is pretty compelling. Now, there's a group in Europe that's pushing strongly the value of the new cognitive behavioral therapy treatment, and they think that it works really well with adolescents and works well in residential. But it looks like our populations may be a little bit different. So what I would say is that we're hoping to basically use the same models that have been used for bulimia and anorexia in this adaptation. It's obviously different, though, because we're doing such an increased focus on emotion, and I think that makes a difference, that we're not just doing a skill-based approach. But and then just to say one more word about family-based treatment, I came of age in the 80s when the focus on family-based treatment in anorexia was very Minuchin-esque, and the idea was you have to separate the kids and separate the parents. So the Maudsley model evolved really the opposite of that. They at Maudsley Hospital, they said, you know what, I think it's the opposite. We should have the parents really work to be the one refeeding the child, and they should be the one taking charge, which really flew in the face of traditional structural family therapy. So when the data first came out, we were stunned, but also really excited because you can do these shorter term treatments with family involvement. What we've learned in some of our clinical work is what you're describing is tricky because you have people in residential where it's highly structured, and then you have to have them practicing as they come and go. And as you say, the mercurial piece of it, because we see so much struggle in that kind of program, can make that difficult. But what I would say in general, I would say the data really strongly support family-based models, and they just haven't been studied in your kind of setting.
Other questions? Let me ask you a question, Carol. In one of our treatment studies of PTSD, we found that childhood trauma and also even genotype of a particular allele predicted response. And I was wondering if any work has been done in this aspect, because there's a lot of emotional focus in the therapy you described, history of childhood trauma and other things like that. Has that sort of thing been examined?
So I'm very happy to have people in my audience who know more than me on this topic. So, but let me say, first of all, what's been found has not been replicated. Do you guys know of anything that's, no? Yeah, no, I mean, I think there's a lot of interest in genotype, but so far we haven't found anything. So thank you for asking that, and we certainly need that. Good. Any other questions? Well, if not, let's thank Carol again for a fine talk.
You have been